Emergency surgeons find ourselves in a quite new situation nowadays, which is attending patients who are potential candidates to an emergency surgery and who have a concomitant infection by COVID-19 virus. What should we do with these patients? Well, there are some descriptive studies which show us that postoperative mortality of patients submitted to a surgery who have also a COVID-19 infection is higher than expected, and therefore some recommendations have been done to avoid or postpone surgery in these patients with a COVID-19 infection. However, postponing or avoiding an emergency surgery may also have its own risks, and it is very important that we clearly understand the actual risk of doing so, of performing a surgery in a COVID-infected patient. Or, in other words, is the higher observed mortality of COVID-infected patients submitted to surgery entirely due to the COVID infection itself? Because if we look closely to those descriptive studies, we see that COVID-infected patients had a more advanced stage, more pathologies, and a worse general state. And it is possible that those factors can contribute to the higher observed mortality, more than the COVID infection itself. Moreover, the pandemic context had more conditionings. The lockdown could condition that patients consulted later to the hospital, to the emergency services, because of fear or difficulty to access. And also hospital collapse could cause that hospitals had more difficulty to rescue patients with complications. All those factors could contribute to the higher postoperative mortality which was observed. And it is very important that we can measure which is the actual impact of these three factors in order to know the real risk of COVID infection itself on postoperative outcomes, and that help us to make evidence-based decisions in each single patient. The COVID-3 study was born with the aim of answering these questions. From the Bellvitge Hospital in Barcelona, we led a registry with 25 participating Spanish hospitals, including all emergency surgeries which were performed in the first wave of the pandemic from March to June 2020, and also from March to June 2019. And more than 5,000 patients were included in that register. First, to assess the impact of COVID infection on postoperative outcomes, we compared the COVID positive patients with the COVID negative patients who were operated on during the pandemic. And we did it so with a statistical method which is called propensity score matching, which consists in matching every COVID positive patients with a COVID negative control who is comparable in everything except COVID infection itself, with similar age, the same comorbidities, similar state at moment of diagnosis. Doing so, we have two groups which are very homogeneous, very comparable in all risks factors except in COVID infection. So when we compared those matched comparable groups, we see that mortality is not statistically higher. That means that the higher mortality of COVID-infected patients has more to do with its general state, its anesthetic risk, its age, than with COVID infection itself. Therefore, when we face an individual patient who can be candidate to an emergency surgery and who has a concomitant COVID infection, the COVID infection should not be seen as an impediment, as an absolute impediment to surgery, but it should be seen, decisions should be made based on individual risks, in individual anesthetic risk and the actual preoperative state of the patients, in a similar way as it was done before the pandemic. Secondly, we wanted to measure the effect of lockdown. If we wanted to see if patients consulted too late, if fear or difficulty to attending the emergency services made that patients had a more advanced surgical pathology at the moment of diagnosis. And we saw that that was not so. Patients operated on, COVID-negative patients operated on during the pandemic had a similar extent of peritonitis and similar inflammatory analytical markers that patients operated on during the previous year. So the worst outcomes could not be attributed to the effect of lockdown. And finally, to assess the effect of hospital collapse, we did a propensity score matching comparison between or among patients, COVID-negative patients operated on during the pandemic with COVID-negative patients operated on during the previous year. As we've told, propensity score matching consists in making two groups which are comparable in age, general state, pathologies, one by one. So there are two very similar groups, except in the fact that they were operated on different years. So when we look at the failure to rescue of these two groups, failure to rescue is the percentage of people who have a complication on the postoperative course and that die as a consequence of these complications because they cannot be saved from it. So failure to rescue during the pandemic was higher than before the pandemic. This was observed in all 25 participating hospitals, and this could be attributed to the context of the hospital collapse during the pandemic.